Hello, everybody, and this is another post-exam debrief I had with the candidate. We will go through the whole thing now. Uh, the first thing to say is that I want to thank the candidate who agreed to allow me to record this anonymously. So we'll start with communication one was eating disorder. The task was to explain to the mother that the child has an eating disorder and will need to be hospitalized and given a feeding plan. Mom was very calm, they understood everything well. The child had had a hypoglycemia and had received IV glucose or oral glucose. There was bradycardia and the BMI was only 13. So the candidate said the introduction went well, everything went well. Step by step management was explained. They also explained that they would be monitoring the child at the ward every day. Mother asked if other blood tests were required. The candidate replied with a yes. There were no major issues and the candidate feels that they have passed. Communications 2 was eczema. The task was that the child was having recurrent flare-ups. They had eczema hepaticum a month ago. Mom was concerned that the child was not improving much despite emollients and hydrocortisone. The candidate explored how to use the emollients, making baths also containing emollients, and spoke about discussion with a consultant and a dermatologist. No issues, the scenario went well, and the candidate thinks they have done well. Then the third was history taking. This was a 2-year-old with a single episode of unresponsive episode with cyanosis and not breathing for a few seconds following an accidental fall while playing. The history of epilepsy was explored, but there was nothing in the past and no systemic symptoms either. There was a history of epilepsy in an uncle. The past history was explored well. The diagnosis was a breath holding spell, most likely, and management offered was reassurance. They also mentioned FBC for iron deficiency and ECG and an EEG after discussion with consultant based on the family history of epilepsy. The candidate mentioned that the mom was to be safety netted and to be provided BLS training, which I think was excellent. Uh, Time was not an issue and the candidate finished ahead of time. Video station 1 was a mastoiditis where the video showed a swelling and redness of the mastoid area and also showed crusted ear discharge on the same side. The diagnosis offered was mastoiditis due to primary ear infection. Questions asked included if there was anything else visible, which the candidate said they could not see anything else. They were asked about investigations, to which the candidate answered with FBC, biochemistry, and ear swabs. Mentioned treatment in the form of admission, ENT referral, and IV ceftriaxone. We asked about complications, and the candidate offered cavernous sinus thrombosis. I feel meningitis would have been a better answer. Video 2 was pyloric stenosis. The candidate feels they didn't do well because they missed the visible peristalsis of the abdomen. They did see the child moving his lower leg abnormally, and they felt that this was a neurological or hip diagnosis. But the stem was of a 4-week-old child with failure to thrive, and questions were asked about hypertrophic pyloric stenosis and about what you would do and how you would manage, and this part was answered well. The candidate feels they may or may not pass this station. The next station was development. This was a 4-year-old child with Down syndrome. The task was to assess fine motor. During history, it was discovered that the child had a global developmental delay in other parameters as well. The child's STEM mentioned that there was no cardiac problem. In the fine motor, the candidate got a little bit confused because initially they felt that the child had an immature palmar grasp and therefore offered a developmental age of 12 to 18 months, whereas everywhere else it was 18 to 24 months. However, later on in the examination, they did see that the child had a good pincer grasp, and so they revised their assessment to 18 to 24 months, which seemed to be the right thing. There was this a question asked about what was the cause of the global developmental delay in Down syndrome. In the historical STEM, it had been mentioned that the child did have a hearing loss. The candidate didn't mention this initially. They mentioned that global developmental delay was a basic feature of Downs and also mentioned that we needed to rule out hypothyroidism. However, later on, the candidate did mention about the hearing loss and said that this would be a factor. The next question that was asked was, who are the main people to refer to? And the candidate clearly mentioned all the guys who are mentioned in the video, but the possibility examiner was looking for some other specialists, and they asked who is the main person to refer to, and the candidate mentioned developmental pediatrician. The next was a CVS case. It was a 6-year-old with a query pansystolic murmur at the left lower sternal edge, grade 2 by 3, no thrill, no heave, well-looking child. And they offered a first diagnosis as VSD and the second as a uh, tricuspid regurgitation. However, they did not offer Still's murmur as a differential diagnosis, which I think would have been appropriate in this case. Investigations and management plans were answered correctly. The next case was examination of the eye. This was a child with meiosis and ptosis, so clearly Horner's, but they did offer Cradle 3 palsy as a differential diagnosis, and then said this is not the case because there were no loss of extraocular movements except for the ptosis. The management was offered as looking for an underlying cause, MRI, and referral to ophthalmology and neurology and imaging. Then there was a neurology case, which was a child with an ataxic gait, and the question task was to already mentioned that the child has an ataxic gait and please examine the upper limb. But nothing was found actually abnormal, but the candidate says that they looked at power, tone, and reflexes, and they were all normal with no hypotonia. The STEM mentioned the ataxic gait, so the candidate probably said that they should have looked for cerebellar signs, which were not checked. And the candidate also mentioned that other candidates also had found the case perplexing. So I don't know whether the benefit of doubt would be given to the candidates because nobody got to the right diagnosis. Finally, there was an MSK case, which was a tall child with Marfan syndrome, having some 4 to 5 of Batten score positivity and therefore hypermobility. The child was not wearing glasses. The candidate was actually asked, why is it not Marfan's? And they answered that they did not have a Marfan's habitus. However, the candidate had failed to actually measure the span of the arms from one hand to the other, or the height, which they did mention in the things to do. But I think if they had done that, they would have clearly probably managed to rule out Marfan's. Also, I asked whether the candidate managed to listen to the heart, and they said no, because they did not think that was a part of the MSK. So I did say that, just as we do related examination at other systems, you could have asked to gain permission to listen to the child's heart, because if there was an abnormal heart murmur in the aortic area or mitral area, then Marfan's would have been more likely. In the final analysis, I think this was probably a child who did not have Marfan but just had plain hypermobility, because Ehlers-Danlos is not associated with a tall habitus. But that's about it. So this was the debrief for this candidate. Thank you all for visiting. Bye bye.